Hey, it's another day where we are alive and so is public health. I'm Jonathan Lyle Sexton. Welcome to Better Together. Happy Pride. This episode lives inside Pride Month on purpose because the story we're telling today is a pride story. It's one that begins in 1981. It moves through the decades as loss, resilience, advocacy, and scientific breakthrough. It brings us here to New Hampshire today, where organizations are still showing up for their communities. We're going to talk about HIV today. That means we're going to talk about health, relationships, and how people care for themselves and each other. Topics that we don't always say out loud, even though they affect all of us in one way or another. So take a breath, get the giggles out if you need to. We're going to talk about sex. We're keeping this real, respectful, and grounded in facts. We'll talk about HIV testing, about how far treatment has come, and about what it means that this is an epidemic. It's the one that many people assume is over. It's still very much a part of our public health landscape, and it is not over yet. As you're listening, here's what I want you to hold on to. This is a story about people, about resilience, about science that has transformed what it means to live with HIV, and about public health work at its best. Meeting people where they are, removing barriers to care, and ensuring that every person is treated with dignity and respect. That includes people of every background, every identity, and every community. Because HIV has never belonged to just one group, and neither does its prevention, care, or the compassion we have for people. So it's time for a pulse check. All right, quick biology, and I promise this is going to be as painless as I can make it. HIV is weird, and I mean that scientifically. Most viruses your immune system has met before, it remembers. See, you get sick, you build antibodies, and you move on. HIV defeats that system almost by design. It doesn't just infect your cells, it hides in them. It inserts its genetic code directly into yours, so your immune system isn't chasing a foreign invader. It's trying to find something that has already made itself at home in your DNA. Which is why just make a vaccine is not as simple as it sounds, and why it took until 1996, 15 years into the epidemic, for researchers to crack the treatment. The breakthrough was combination therapy. Hit the virus with several drugs all at once, each targeting a different part of how it replicates. The odds of HIV mutating to resist all of them simultaneously are essentially zero. For the first time, HIV could actually be controlled. Today, many people living with HIV take a single pill once a day. And if that treatment works, and it usually does, they reach something called undetectable viral load. Which brings me to a letter I need you to remember this entire episode. U. U equals U. Undetectable equals untransmittable. A person living with HIV who is on treatment and undetectable cannot sexually transmit the virus to their partners. It's not likely to, it's cannot. This is World Health Organization supported, clinically validated, and somehow still one of the most underknown facts in sexual health. But, and this is a part that matters, you can't get to U equals U without knowing your status, which is why testing isn't just a medical procedure, it's the entry point to everything. Now that we're done with some science, let's talk history. June 5th, 1981, 45 years ago, to the day that this comes out, the CDC published a 5-paragraph notice. 5 men in Los Angeles, a rare pneumonia, no explanation. It was dry, clinical, and nobody knew what it meant yet. By the end of the year, there were hundreds of cases. By the end of the decade, hundreds of thousands of deaths. In the early years, the medical community was largely operating in the dark. There was no test, no treatment, and no clear understanding of how transmission worked. The CDC's early name for the condition was GRID, Gay-Related Immune Deficiency, a name that reflected the limits of what was known at the time, but not the full picture of who was actually affected. AIDS would eventually reach every corner of American life. What's remarkable about this period is what communities did in the absence of answers. Volunteer networks formed almost overnight. Mutual aid organizations were built from scratch. People who had lost friends and partners became caregivers, advocates, and fundraisers, often simultaneously. The Gay Men's Health Crisis was founded in New York in 1982. It's a group. In 1987, the AIDS memorial quilt was displayed on the National Mall for the very first time. It eventually grew to over 40,000 panels, each one a name, a life. The testing arc, looked at from where we are today, is honestly remarkable. In 1981, there was no test at all. Doctors are diagnosing based on symptoms alone. By 1985, the first FDA-approved HIV blood test is available, and the blood supply began being screened. The 1990s brought rapid tests with results in hours, and today you can swab your gum at home, wait 20 minutes, and know your status. No clinic, no blood draw, no appointment. Modern fourth-generation tests can detect HIV as early as 18 days after exposure. The science moved fast. Access, though, hasn't always kept pace. That gap between what is medically possible and who can actually reach it is where a lot of the remaining work lives. Let's look at where things stand right now, because the numbers tell an important story. Over 38,000 people received an HIV diagnosis in the United States in 2024. Gay and bisexual men accounted for 67% of those new diagnoses. People ages 25 to 44, 60%. It's important context for public health outreach, but it's only part of the story. HIV affects people across all communities, and risk is shaped by access to care, education, and resources, not your identity alone. Annual infections have dropped by more than 2/3 since the peak in the mid-1980s. That's real, meaningful progress, and the science behind it deserves a lot of credit. But the data also shows that progress isn't reaching everyone equally. African American and Latino communities continue to experience disproportionately higher rates of new diagnoses. Not because of any difference in risk at the individual level, but because of the real documented gaps in healthcare access, awareness, and connection to services. PrEP, P-R-E-P, a medication that is more than 99% effective at preventing HIV in HIV-negative people, has been available since 2012. It works, and yet the communities with the highest need have the lowest rate of PrEP use. Knowing a medication exists and being able to get it, or even afford it, find a provider who offers it, feel comfortable asking for it, those are all completely different things. Delays in diagnosis and treatment are linked to significantly worse health outcomes. That's a solvable problem, but it's not fully solved yet. And it's exactly the kind of gap that well-connected local organizations are positioned to close. Which brings us to today's guest, an organization built in the middle of this epidemic, still standing, still doing the work right here in New Hampshire. Today, my guest is someone from an organization that has been doing the unglamorous, essential, life-sustaining work of closing that gap for 30 years. Merrimack Valley Assistance Program, MVAP, was founded in 1995, born directly out of the volunteer networks that emerged during the AIDS crisis, when communities stepped up to support one another in the absence of clear answers. They are one of 4 AIDS service organizations in New Hampshire. They do case management, housing assistance, transportation, food support, HIV testing and prevention, medical referrals, insurance navigation, Ryan White Care Act, enrollment, education, and outreach. Oh my gosh, you guys do everything. They serve Manchester, Concord, serving Manchester, Concord, Laconia, the Lakes region, North Country, the whole entire state. Daniel Amato is the executive director of MVAP, and someone who has dedicated his career to what he describes as connection to care, reducing the barriers, keeping people engaged, and making sure that when someone needs support, they find it. Thank you so much for being here, Daniel.
Yeah, thank you for having me.
Could you do a little introduction of your organization, your kind of timeline of being there, just where you are, what your organization does, who you are, and yeah.
Yeah. So my name is Daniel Amato. I'm the executive director for Merrimack Valley Assistance Program, or MVAP. We are New Hampshire's largest HIV and AIDS service organization, serving primarily Manchester, Concord, Laconia, Lakes region area, and northern New Hampshire. We provide HIV services to folks living with HIV and AIDS that are at or below 500% of the federal poverty level. We provide HIV case management, support services, housing assistance, and medical referrals. MVAP started off as a volunteer-based, no federal funding, just a group of volunteers to kind of combat the AIDS crisis at the time, located in Concord. So MVAP began receiving federal funding in 1998, and we've been in secured federal funding since then. We have primarily 4 different grants that we utilize for our services. One is through the state of New Hampshire, the other one is through Boston Public Health Commission, and then the other 2 are from HUD, the other 2 are from HUD, Housing and Urban Development, which is our housing for opportunities for persons with AIDS. Those are primarily our grants that cover our services.
With it being federal funding, just coming from a nonprofit ourselves, we've experienced loss of funding. How has the shaky federal landscape right now affected an organization like yours? Because when we talk about very specific things such as like DEI, probably lists off a lot of things that might check off your organization. So have you guys felt any effects from that, or?
Yeah, I would say that we are extremely lucky that we have not been impacted funding wise through this administration transition. Our funding has been intact and secured. I will say that the effects that I've felt have been through my grant applications and through different wording and terminology. So I would send in an application like I would 3 years ago, and they would send it back and say, you need to delete XYZ because we don't want it to flag in the system. That was one of the things when last year I was applying for a HUD grant, and that happened to me, where I wasn't even thinking of it. I just applied for the grant, talking like I would normally talk, and HUD sent it back and was like, I need you to delete all of this.
Interesting. Yeah.
It didn't affect our funding. We still got the funding, which we are very grateful for. But that was like one of those situations where I was kind of like, wow, this is real life.
Yeah.
Like, this is really happening. They don't want us to use these terms that are, considered bad in their eyes. So that was one of those effects that I have felt personally as, someone that's applying for grants for an organization. I would say that like our funding has been intact. We are very grateful that we have not had any cuts.
Yeah.
I have not had to cut any staff. I haven't had to cut any services at this point, which again, like I really want to hit hard that we are extremely grateful for that, because I know that there are a lot of organizations that can't say the same thing.
Yeah. I think that's exactly where we're sitting right now as our organization of, we haven't been hit too hard by it, but we are starting to be very specific about how we word things. Even when writing like this episode, we went through it multiple times to comb through to make sure we weren't leaning too hard on any specific language, easing up. And I think that's just a reality of what we're in right now. Not the situation, but just, I think there's always a way to get your message across. And sometimes it just has to be adapted, right, to whatever the median is that you're trying to paint your message with. You just sometimes have to adapt it to make it where it's a little bit more accessible to everyone. And we've always had to do that. You've always had to talk about accessibility. And right now, just what is accessible has shifted a little bit. How you frame your message, how you frame your language around that. Overall, how did you get started in this work to see where you are now as an executive director, right? Where did you get started, and how did that path lead you to where you are today?
So really what happened with me was I was at the right place at the right time. I will be very upfront and honest when I say that. So I started at MVAP as a case manager back in 2021, and I would say that I got to become the executive director by gaining experience as a case manager at the right place at the right time. So for instance, we did not at the time have an executive director, and the board was primarily running the organization at that time. And so the board looked at the rest of the staff to help for things that needed to be done day to day. The board is volunteer, so obviously they have far less availability than a paid staff member does. And so at that time, I kind of, gained all my track and volunteered to do different reports and interviews for case management and things like that I didn't really have much experience with, but offered my kind of services at that time. Yeah. And so that really helped develop me into becoming from a case manager. I was then the director of office operations. And so then that kind of made me oversight of all three offices at that time, when we did have a location here in Laconia, Concord, and Manchester. And then from there, I then transitioned into becoming the executive director. So I would say that my role specifically was really the right place at the right time. I did not have admin experience at an executive director level, but I would say that the tasks and the activities that I did leading up to becoming the executive director kind of showed the board that like I had what it took.
Yeah.
I had the drive to be able to do it, and also just the passion for the services that we offer. I think that what makes MVAP really different than a lot of other different organizations in human services and maybe even public health in general is that you can have someone that is great as an executive director because they have an admin mindset. They know how to budget, they know how to write grants, they know how to do all of these admin tasks. But at the end of the day, for my organization, you also have to have a passion for the people that you serve.
1,000%.
And people that are living with HIV. A lot of the time, when I tell people what I do for work, they're like, oh, that's still a thing. And I have to remind people that, like, yeah, it's not in numbers of what it was in the early 2000s or in the 90s or the 80s. But yeah, like New Hampshire still averages about 30 to 35 new HIV cases every single year.
Oh my God.
Those are still 35 new people that are diagnosed that we help. And so I have to remind people of that, like, yes, it's still a thing. And also, too, that there's still no cure. So people who are living with HIV from the 80s and in the 90s, they are still living with HIV today. And so they
still need help.
Exactly. And they still need help with paying for their medications. They still need help access to getting their labs done and going to their providers and going to their pharmacy to pick up their prescriptions. Like, they still need help in all of those ways. That has not changed in the decades of, what we know of HIV today.
Yeah.
That hasn't changed. And so I have to remind people of that like this is still really needed.
I think one of the questions that instantly kind of popped into my mind as you were going through this is, what does someone who lives with HIV, we can take it from either maybe someone who got diagnosed maybe 5 years ago, right? I'm assuming the workload for someone who just got diagnosed and someone who's been diagnosed since the 80s are two separate things, because one person's probably used to what they're going through and one person is just learning it all. So someone 5-10 years ago, what is their average? What are the things they have to deal with? What do they have to go do? Not maybe what labs, but when you talk about labs, how often are they getting labs done? What might they face in the housing? I think that is a big part of this conversation that gets overlooked because most people just see HIV/AIDS. They think of certain populations, they think of certain people, and then they just think of, well, got to deal with it for the rest of your life, right? Exactly. And that's where it ends of the thought process, not what do they go through on a daily basis? What are they facing? What are they having to think about when they're doing labs or planning just like what jobs they can get, because they probably need flexibility where they can go and take time off and not have to worry about, I need to be at this spot at the right time.
Yeah.
Right. So what are those things?
I would say, one thing that I think of when you said that was, we've made so many medical advances in the HIV realm, since the early days, right? I mean, we are down to one pill a day or even a bi-monthly injection now for treatment of HIV. Like, that's huge in and of itself. That is a huge change of what people saw in the early days of HIV and AIDS when taking, multiple pills a day and them not working and people dying of AIDS. I would say that one thing that hasn't changed is the stigma and the fear of maybe discrimination or people finding out their status. That has not changed whether you were diagnosed 25 years ago or you were diagnosed last year. And I see that every day with my clients who, again, some of these clients, they've been part of the organization for decades. And then other clients who are newly diagnosed, like they've only been part of the organization for 6 months or a year. And I would say that what I see is that stigma still exists between both of those people, regardless of when they were diagnosed. And I think that that's really what comes up when we talk about HIV is the stigma and the fear of being discriminated against or being asked questions that are really just invasive. Yeah. Especially for like people that are newly diagnosed. And I think that when people are newly diagnosed with HIV, a lot of the conversation that I have with them is, paying for their medication. And like, how am I going to pay for this? How am I going to, get my labs done every 3 months or every 6 months? Typically, when someone's newly diagnosed, they get labs every 3 to 6 months, and then it typically goes to once a year. A lot of clients, it really depends on their provider and what the provider wants based on, their body, their labs, what their baseline is. But I would say a lot of our clients now at this point usually go once a year or every 6 months
so it's not
for
bad.
labs. No, it's not bad at all. But again, you have to make sure that you have access to that. A lot of our clients maybe don't have transportation. They don't have their own cars. So getting to a provider's office, especially here in northern New Hampshire.
I was going to ask that about the North Country.
Exactly. A lot of our clients travel very far for their provider visits. Good thing that we have telehealth, but telehealth is only so helpful. You can't do labs. So you still have to find a local lab like LabQuest or, a smaller kind of lab to go to in order to get those labs done. So transportation is huge. We provide a lot of transportation to clients to get to their appointments, whether that be for medical or other support services. But yeah, I would say that hasn't changed, in looking at the landscape of HIV. The discrimination fear of being discriminated against due to their status, or the stigma behind, people asking really invasive questions or just, wondering like how this happened or like why did it happen, or, just being really uneducated about HIV. And I think that's huge.
Yeah. I think something that comes to my mind is that the general populations that you're thinking who are dealing with this are probably living in the cities, right? So a lot of people think of this as a city problem. But then when we talk about New Hampshire, on a federal definition level, I believe there's maybe Nashua, Manchester, maybe Salem. There's I would give it 5 cities in New Hampshire. The rest are rural. Like even Concord is rural by federal standards, surprisingly. We have a lot of resources in Concord. But Laconia would be rural by many differences. But in New Hampshire, it's considered a city, right? So when we're talking about where the population and the demographics are, how many people are you seeing from the rural areas in New Hampshire versus the city?
That's a really good question. I would say, you're spot on. I would say that a majority of our clients live in the city. I would say, if I had to guess, I would probably about 75% of our clients live in the city, whether that be Manchester or Concord or a close surrounding town where it's not really too far away. I would say that a majority of our clients live in those demographic areas. I would say that those clients really live in those geographic areas. However, we do have clients that do live in the Lakes region and northern New Hampshire. And even for me as the executive director, sometimes I forget. Yeah. And I have to remind myself that I still have clients that live 2 hours north of Manchester. Or 3 hours north of Manchester. And it's their access is equally as important as someone who lives a block away from their provider. Yeah. And so sometimes I even forget, and I have to remind myself, there are still people living with HIV that are 3 hours north that still need access to these things. And that's equally, if not more important, because it's much harder to get them into care and retained into care because they might not have access to that. And so what does that look like on our end? We have to arrange, a taxi service or some other volunteer to help get those clients who might not have transportation down the 2.5 hours to a medical provider, or establishing a telehealth appointment, whether they have access to a tablet or a computer. We try to investigate those things and see where we can help. But I would say that it's sometimes really challenging to have such a large geographic catchment area as we do, because our clients need so many different things. So we might have one client that has stable housing up north, but they have no transportation. Whether, and trying to navigate them getting access to medical care and support services through transportation is more challenging, not only from a scheduling and seeing who has availability, but also funding wise. It obviously costs a lot of more money to pay a taxi driver to drive 2 hours and then wait for their appointment and then drive another 2 hours, versus a quick Lyft ride in the city might only be $10. So I think that is a huge gap in our services of trying to navigate people who need more transportation because of where they live, more mileage, more time in the car, versus someone who just needs a quick Lyft ride in the city that might only be $10, versus someone else that lives in northern New Hampshire. It might cost $500.
Yeah.
Depending on where they need to go or how long they need to wait.
Yeah. I think that brings up a great question that I instantly go to of what are the underrepresented services that need to be offered to people who have HIV/AIDS, right? I think most of our brains probably go straight to medical services, but then you were just talking about the transportation issue, right? What are some of those underreported things that people have to deal with when they're going through HIV/AIDS?
Yeah, I think that I would say that New Hampshire, where I'm located and where most of my clients are located, I would say that medical access is not an issue for the most part. I would say that we have access to infectious disease providers in various locations of where my clients live. I would say sometimes, it does get challenging. Like if a client lives in northern New Hampshire, for them to travel to Lebanon or down to Bedford or Concord, wherever their infectious disease provider is located, that can get challenging. But I would say that they're still there. They're still stationed there. They still have access to it. Whether that means, we help with transportation down there through a taxi service or, scheduling through Medicaid, a ride through them. I would say that is not necessarily the challenging part as far as having access to a medical provider, but the access to get there sometimes is what is challenging. And then I would say looking at all of our clients at a landscape or at a bigger picture kind of thing, I would say that our really prevention and just knowledge behind HIV in general is where I find the biggest gaps in care. So for instance, in the city of Manchester, where we are headquartered and where a majority of my clients live, we need prevention in the city of Manchester. Yeah. We need people to know their status. We need people to have access to medical care, whether it be HIV medical care, infectious disease, whether it be primary care, whether it be substance use care. We have so many different we have so many different needs as far as medical service goes. And then also too, it kind of plays into part of that is affordable housing. Affordable housing has been a hot topic lately. Yeah. And it seems like there isn't enough affordable housing. And
housing in general.
Housing in general. And if it is affordable, is it suitable?
Yes.
And so I think that's a huge challenge that we are finding. People need access to these things. And I would say that people need access to medical services as well as access to them, as well as transportation and food and housing. Yeah.
During that, you mentioned something. For me, I have a lot of questions when it comes to HIV/AIDS because it wasn't something discussed around me. And part of that is most likely I grew up in Idaho, right? Conservative culture. So HIV/AIDS is very stigmatized. How are you having people deal with that stigma? Because I'm assuming one thing that we deal with here with prevention work is that there's a stigma around those who have a substance use problem or whatever, because it's they did this to themselves. And we're really trying hard to work on that stigma. I used to work in a food bank. There was a huge stigma around anybody who would have to go to a food pantry.
Exactly.
Right. How are you addressing and dealing with that stigma? Or what are some of the things that you might want people to know to ease that stigma? If you could just speak to, everybody right now and just say, hey, get this through your head of here's some thoughts.
Yeah. I would say that the culture that I try to foster at MVAP is really clients have the autonomy for the services that they need. And that's really important to us as a team to really foster that environment where clients have access to the services that they need, but they also have the ability to have services or not. It's their choice. And, something as simple as we have a food pantry. We offer perishables, non-perishables, household products, personal hygiene, cleaning supplies. We have a whole plethora of different things that we offer.
I like how you're putting it as autonomous, right? Having people be able to make their own decisions, their own choices, because I think a lot of times when you're talking about any marginalized group of people, anybody who is going through any situation, you start thinking of them as, oh, I need to help them, right? And so everything I do is helping them, right? And we forget that it's a person who is living through whatever situation they're living through. And it goes through so many different groups of people, and you could insert whatever problem you want to insert here. But you want to give them the autonomy so they feel like a person again.
Exactly.
Right? They can start oh yeah, I might be going through this, but I am a person going through this, right? We talk about person-centered language, person-first language, a person with.
Exactly.
Right? Rather than anything else. Because when you have that person able to make their own decisions and they can start helping themselves, it helps them in the long term. It helps them 5 years down the line when they're needing to make a choice. They're like, oh yeah, I'm this person. It's not that they have been helped every moment and then all of a sudden they're on their own. It's I have made the choices of getting help. I've made the choice to ask for help. And during asking for help, I was able to make the decisions within my journey.
Exactly.
Where else do you kind of struggle with people maybe not always feeling like they can be autonomous, but you try to allow them to be autonomous in what your organization offers?
As a client or people on the outside?
Either or, but clients primarily.
Okay. I would say something else that I see is regarding housing assistance. So we have a couple different activities as far as housing goes. We have vouchers similar to Section 8 that we pay for, monthly vouchers for clients. We have emergency assistance. And I think that some of the stigma behind needing emergency assistance exists. So, some clients, they really will try to, stretch their budget or stretch their wallet a little bit too thin because they don't want to admit that they might need help this month paying for their rent. And so I think that we really try to encourage clients to let us know if you have expenses that come up that you weren't expecting. Your car breaks down or you have a medical expense, you went to the ER and you have those emergency expenses. We can help in return pay your rent and make sure that you're not late or you're not going to be served an eviction notice or your utilities are not going to be shut off because you were worried about paying this emergency, bill. And so I think that exists where clients, again, it's kind of similar with the food pantry where clients, maybe their pride gets in the way a little bit.
Yeah.
They're just kind of embarrassed to admit that they might need help. And so we really try to foster an environment where it's it's not a big deal. It's okay.
Yeah.
We all in different areas of life, we all need help. At some point, we all need help, whether it's through funding, whether that's through emotional support, whether it's through, food pantry or, we all have access and we all need access at one point, I should say, to different services, to different support. And I think that trying to just make it not a big deal is really important to the team at MVAP to serve our clients and make sure that they know it's all good.
Yeah, we all struggle asking for help too, How often do you have people struggle with even getting their foot in the door to your organization? Do you, with HIV/AIDS, it is an infectious disease. So there is some push of like, okay, I have a disease I need to deal with, so I need help. Right. But how often do you struggle with a lot of people trying to get to you, getting their foot in the door, and like that asking for help of just the initial step of coming to y'all? Or I don't know, is everybody just either instantly referred to you, or are they like, you know what, I want help, and everybody's okay with it, and nobody ever struggles with asking for that initial step of help?
Yeah, that's one of our biggest barriers, I think, is the linkage to care and, getting them in the door.
Yeah.
I would say it's hard too, because, you don't know what you don't know. So there are people living with HIV that don't know it yet. That's a known fact. There are people in the community that are living with HIV that might not know it because they might not have been tested, or they might have been tested and then had an exposure later on that they didn't think of, and there it is. And so I think it's really challenging sometimes to, we have partnerships, like specifically in the city of Manchester, we have partnerships with our community health centers and our mental health centers. And they have clients that they see they know are living with HIV because the client has told them, but they're not engaged in my program. And why is that?
Yeah.
Well, it's because they have other barriers. Maybe they're unhoused. Maybe they don't know where they're going to be located. Maybe they have substance use, and that is preventing them from getting into our office to have another appointment. And so I try to remind people that, like, when you are not sure where you're going to be sleeping at night, that's really on the forefront of your mind.
You're not thinking about anything else.
You're not thinking about anything else. You're thinking about, oh my gosh, it's going to be pouring tonight. Where am I going to be sleeping that's going to be dry? Or, it's going to be really cold or really hot. Like, how am I going to survive tonight?
Yeah.
Versus, oh yeah, I should make that appointment with MVAP. That's just not even in the realm of what they're thinking about. And so I think reminding people of that those barriers exist and are real. And that's where we really try to come in. We try to, we really try to get people in the door. We really try to meet people where they're at. And I think that's also like talking about the environment that we really try to foster is truly meeting people where they're at. And it's like, it's one thing to say, yeah, we meet clients where they're at. It's another to actually do the work to make sure that you are doing that. And so one of those things that I can talk about today is like, we are a registered syringe service program. That we weren't ever that.
Yeah.
We've only been in SSP for, I think, 2 or 2.5 years now.
Oh, wow.
So it's like relatively new for us. And that service in general, we adopted due to seeing the need for that service in our clients. And what we're finding now is that is really the carrot that gets some of our clients in the door.
Yeah.
Even to just meet, even to just sit down and talk about
anything else.
Anything. And it doesn't even have to be HIV related. Of course, we hope that it is HIV related, because we want to talk about their diagnosis. We want to talk about getting them into medical care. But even if they come to our office and just use a few of our services, and we have a conversation about, hey, make an appointment with me next week, and we can talk about, your medical services then. Or just meeting face to face. I think giving a name, having a face to a name, and not just like, oh yeah, you should call this random organization because they'll help you. Being able to actually help people and have a face to a name, or a face to an organization, is extremely important for clients who might otherwise be harder to reach. They might then feel comfortable to come back.
Yeah.
They might feel comfortable to come back and get services that they might have skipped out on for months or even years, because now you developed a good rapport with them.
Yeah. Yeah. I think that's the way to do it. I think there always has to be that carrot in the door. And I love how that's how you guys are offering services that will get people to you. I think that's awesome.
I think because it's HIV and because it's an infectious disease, I think people like to key in on the moment it happened, or like the situation of why it happened,
Yeah.
And I think that if you ask people living with HIV, like one of the questions that is really stigmatizing to them is, well, how did this happen? How did you get HIV? And it's like, first of all, it's a really invasive question.
Yeah.
Second of all, they might not know. And third of all, it's really none of your business. And so I like to have this idea where, like, let's live in the now. Those questions, the answers to those questions they really don't matter.
Yeah.
The services that we provide does not matter. Like the answer to those questions is not going to tailor the services that we offer you, right? And so I think people are just curious and honestly nosy about that.
It feels like a disease that you have the right to ask those questions about.
Exactly.
Versus, like, I think blowing my mind, just like I really like the point you make of like lung cancer, right? You don't start then being like, well, shouldn't have smoked those cigarettes, right? You're like, oh my gosh, you have lung cancer?
Yes.
Let's get you treatment.
Yes.
Right? You don't.
Oh my gosh, I'm so sorry that you have lung cancer.
Yeah. It's like, that's like, instantly versus HIV and AIDS. It's like,
yeah.
Too bad.
And I think that just goes back to like the stigma behind HIV. Because like if you were to ask me like lung cancer, for instance, I think people are going to be far more empathetic to you having lung cancer than to you having HIV. Well, because, you asked for it. Yeah. And I think that right there is like the stigma behind HIV that like these other health conditions don't have. And so like to my earlier point of trying to compare this to other health conditions, obviously I'm very aware that the other health conditions don't have the stigma that HIV does. But I think in a way, the only way to combat that stigma is to normalize it. Yeah. And to make it just like another health condition. And I think that that's really the only way to stop the stigma and to, cut it is to normalize it just like any other health condition. Yeah. Just start having the conversations on a normal basis. Exactly. Right. I think, like we are doing this conversation in Pride Month, right? Yeah. But for like, sure. Why couldn't we have done it any other time? Right. Like we're doing it now because it's a pointed conversation, right? So it's a good time to have the conversation, but I like the point of you're making of just have the conversation, talk about it whenever, right? Make it another health condition, make it something that we'll talk about with equal weight to lung cancer, heart disease, anything else, because that's what it is. It's just another medical disease. Yeah. And I think that's a great way I like that landing point. And before we get you out of here, I have a bunch of rapid fire questions. Okay. So perfect. First thoughts that come to your mind. Okay. One word to describe your work. I would say for my work specifically, I would say the word that would describe my work would be empathy. Having the empathy to work with clients living with HIV, having the empathy to know that this is normal, asking for help is normal, whether you have HIV or not, trying to like normalize that, it all stems from just having empathy for people. I love, great answer. What's the best place in New Hampshire? The best place in New Hampshire? Best place in New Hampshire. These are questions both about our conversation and just random questions. So what's your favorite place in New Hampshire? Yeah, that's a good question. I would say New Hampshire we are so privileged in New Hampshire to have both mountains and the water. So I would say if you are on the water or you are in the mountains, you are golden. You're living it up. You're living it up. Like we are so fortunate to have lakes, to have access to the beach and, the ocean, and then also just like drive a little north and like get into the mountains and like the scenery, or whether you like hiking or not, like the scenery of it all and the leaf peeping in the fall. Yeah. Like we are so fortunate in New Hampshire to have all 4 seasons and to have access to like just different areas of nature. And I would say if you're out in nature, that's the best place in New Hampshire, is to just be in the nature. When looking up research for this show, were you featured in a magazine? I was, yes.
How does the fame ever get to you? How does it feel to be?
I have to stop people asking for my autograph all the time. No. So I was featured in Pause magazine. They reached out to me and just wanted to learn about our services, and I was like, sure, why not? Heck yeah. And so I did an interview with them, and it was really cool. Like just talk about our services and what we offer. It was really cool to be part of.
What's your go-to desk snack?
Desk snack. I've been on it's candy, but I've been on a strawberry cream saver kick lately.
What's a cream saver? What's a strawberry cream saver?
It's amazing.
What?
It is like a lifesaver.
Okay.
Only like strawberries and cream.
So it's like
I have a dish, and I messaged my staff and I said, hey, I have strawberry cream savers on my desk if anybody wants one. And so they'll just come in and grab one and then leave. I've been on a kick of those.
Okay.
Yeah.
Okay. I like that.
Yeah.
I'm going to now have to look into it.
Yeah, they also have orange.
Okay.
I would say strawberry is better.
Strawberry's better?
In my opinion.
You're a strawberry. Are you a strawberry or orange person just in general?
General, I would say strawberry.
Okay.
Yeah.
So like more the sweeter than the citrusy.
Yes.
Sour. Okay. Are you a campfire or a front porch person? If you were just like going to go relax, you want to be at home, or do you want to be out like having a campfire?
Yeah. I would say campfire, I think.
Okay.
Yeah.
That makes sense for your like nature.
Yeah.
That you were talking about.
Even just like a fire in the backyard, it's just like, you can't beat that.
Yeah. That's how I am.
Yeah.
I prefer a fire in my backyard versus, I don't have much of a porch. So like sitting on it's very awkward.
Yeah.
I have a deck in the backyard, but like I like the campfire in the backyard.
Yeah.
That's one of my favorite things. What's your favorite color?
Gray.
Gray.
Yeah.
There sounds like, is there anything to that, or are you just like gray?
Well, I always have to follow up because then people ask me.
Yeah.
And so I always have this answer of like, gray is just very like elegant. It's simple. It goes with everything, I just think that like, it's different.
Yeah.
It
Gray is not one you hear a lot.
exactly, which is why I like using it, because people expect me to say blue. Because everyone's favorite color is blue.
That would make sense.
Exactly. So
As I am wearing all blue minus my tie, and then there's blue lights in here.
Yeah.
Favorite color is purple, though.
Really?
Yes.
Yeah.
So I'm not like I was not a blue fan either.
Yeah.
So
I mean, I love blue, but I think that like
who doesn't love blue?
blue is a staple of colors,
but
right?
it's not number one.
It's not number one. I think
It makes top 5 every time.
maybe even top 3.
Ooh, top 3. Okay.
Honestly. But like gray is just like typically goes with everything. You can do a lighter gray, you could do a darker gray. I think I think gray's the winner.
I love that. What is one thing you wish you could do by just snapping your fingers?
Transport. Yeah, 100%.
Just like boom.
If I could just be like gone in Manchester or here this morning.
Oh my gosh.
Didn't have to worry about driving or traffic or the
That would be
construction.
nice.
We're back into like construction season, so it's like,
right
half
before
of
bike week.
half of the highways, gone.
It makes no sense right now why they chose it.
Yeah.
Where both my wife and I were like, right before bike week, y'all are gonna just be ripping up 93.
Yeah.
Okay.
Yeah.
That was an option.
Yes. If I could just transport in a snap of a finger, that'd be my go-to.
I like that answer. I think save me so much time. I get my podcasts in.
Yep.
I have a 45-minute drive, 40-minute drive down to Concord. So it's like I get my podcasts in both ways, but it would be nice on certain days to just be like, boom, there, boom, back.
Exactly. Save so much time, energy.
Yeah. Do you have any siblings?
I have a sister, older
You have a sister? Older sister? Mm-hmm. That makes it, the next question was going to be, do you have a favorite sibling? I like asking, do you have a favorite parent? I like asking that to see if you have, but also like some people just don't. Yeah. Either they like them equally or they dislike them equally.
Yeah,
there's trauma sometimes.
There is trauma. I would say in my family, there's an ongoing joke that like I am a mama's boy and my sister is a daddy's girl. Like,
okay.
Like for sure, like I always have my mom's back, and my sister always has my dad's back.
Okay.
Like
each one of you got one.
Through and through. I'm gonna stick up for my mom. My sister's gonna stick up for my dad, and like hopefully we'll meet in the middle sometimes. But like, yeah, I would definitely say I got my mom's back.
Okay.
Yeah.
And then if you could ban one cliche health saying forever, what would it be?
Dirty.
Dirty. Okay. You want to dive into that? I like that. I think that is just like...
Yeah, like dirty and clean. It's just like, oh, I'm clean.
There's so many other things.
It's like having an STI makes you dirty. It's just like, well, unfortunately, STIs are very common.
Yeah.
And it doesn't make you dirty.
No.
Yeah, and I think that is like the stigma behind HIV too.
Yeah.
Is like being dirty or like being clean. Like, oh, I was just tested, And like, yeah, I would say whether it's HIV, whether it's like syringe usage, like clean or dirty needles, I would say I would just like to like X that saying.
It makes it black and white.
Yeah.
Rather than living in the gray.
Yeah. It also just makes it good and bad.
Yeah.
And like, yeah, nobody wants an STI.
No.
Like nobody wants to transmit an STI. Like, but it's also unfortunately very common and normal to be sexually active, to, have an STI once in your lifetime, like, or 2 or 3 times, like, depending on your activities, like, it's very normal. And I think that, like, normalizing that and getting away from, like, the clean, good versus bad, dirty kind of stereotyping is, like, just something that drives me insane. So.
I like that.
Yeah.
Final question.
Yes.
What gives you hope?
I think what gives me hope is community. Whether that be my work community, whether that be like, a community with a shared purpose or interest, or I think that like, no matter what the federal landscape looks like, no matter what, is going on in our country or the world, I think community is going to lead us through.
Yeah.
I think the bond of community, people working together with a shared mission, shared interest, a drive to see change. I think that's what's going to pull us through is community.
I love that answer. I think that is whatever's going on above us, like as long as your community is, you have your community, you have your people that you can rely on, you can get through a lot.
Exactly.
So thank you so much for being here, Daniel. It was great.
Thank you so much.
It was great.
So fun.
Yeah, I loved it.
Awesome. Thank you.
I'm so grateful for the conversation I was able to have with Daniel today. I think it brought a lot of meaningful discussion to something that doesn't get discussed a lot. I totally was mind blown and will be telling everybody that you should really consider HIV and AIDS just another disease like lung cancer when we're talking about stigma, right? You're not going to complain and you're not going to say, well, you deserve it to someone with lung cancer. But HIV is the same way. We should have empathy for the people who are dealing with it and figure out how we can help and serve them best. It's best not to look into the past, but to look forward into how to treat it in the future. Subscribe and follow so you don't miss other conversations just like this. Find us at pphnh.org or on our socials at pphnh. You can also check the full cut of this video on YouTube. The conversations always go long, and we always enjoy putting the videos on our YouTube. Better Together is a partnership for public health production. It is written by myself, Tessa, and Emma, which is at least one explanation for why I am told we need a little bit more science and less humor when we're making any claims. Our producers are myself, Jonathan Lyle Sexton, and Emma Peterson, with technical direction from Tessa Donahue. Thanks for being here, and we'll see you next time.